Now let's talk about acute pancreatitis. So let's first orientate ourselves with the diagram that I've drawn up here. We have the stomach, and we know the stomach leads into, via the pyloric sphincter, the duodenum, which is the first part of the small intestines. Now you can see the duodenum curves, and within the curvature of the duodenum, that's where our pancreas sits. Now we have the head of the pancreas, the body of the pancreas, and then the tail of the pancreas, which sits on the surface of the spleen. That's what this little guy is here, the spleen. Now we've also drawn up the liver and the gallbladder because we need to have a look at the ducts associated with the pancreas and also the ducts that are coming from the gallbladder and liver going to the pancreas as well. So you've got your hepatic ducts and your cystic duct, and then what you've got is the common, all of it coming together for the common bile duct. So the common bile duct, so let's label that now. The common bile duct. The common bile duct is going to come together with the pancreatic duct. And when they come together, they form the ampulla of the pancreas, or the pancreatic ampulla, which then turns into this area here, which is the sphincter of Oddi. And this is where whatever is being released from the liver and gallbladder, and also what's being released from the pancreas, is going to enter the duodenum. The question is, what's being released from the liver and gallbladder and what's being released from the pancreas? Well, you should know, first of all, that bile is going to be released from the liver and gallbladder and squirted into the duodenum. Why? Because bile emulsifies fats. You're going to have big globules of fats coming through from the stomach, because when you eat a burger, for example, your mouth or your salivary glands don't produce much lipase. This is the enzyme that breaks down fat. Your stomach doesn't either, which means by the time that fat gets to your small intestines or the duodenum, it hasn't really been broken down. So it's in these big fat globules. We need to break that down. First, we need to be able to emulsify it, to turn it into smaller, more manageable pieces of fat. That's what bile does. It's like detergent. It emulsifies it. The other thing that happens is that you can see I've drawn these little groups of cells in the pancreas, and these groups of cells are called acinar cells. Now what acinar cells do is they release the pancreatic juices. What are pancreatic juices? Pancreatic juices include the enzymes, so the molecular scissors that can break down the proteins, fats, and carbohydrates. So this includes proteases, amylases, and lipases. Proteases break down proteins, amylase breaks down carbohydrates, lipase breaks down fats. Now, if we look at the protease that are being produced by the that are produced by the acinar cells within the pancreatic juice, these are going to be enzymes such as trypsinogen and chymotrypsinogen, and as you can see, they end in OGEN. Now what that means is, when you see the suffix OGEN, it means that it's the stored and inactive form of that particular molecule. So when they're released, so when these proteases, trypsinogen and chymotrypsinogen, are released from the acinar cells into these ducts and then squirted from the pancreatic duct through the pancreatic ampulla and into the duodenum, they are inactive, which means they can't break proteins down. So how do they break proteins down? Well, they break proteins down because you've got a group of cells here lining the walls of the duodenum called enteroendocrine cells. Now these enteroendocrine cells release something called enterokinase. And what enterokinase does is enterokinase comes along and it chops off this OGEN of trypsin. Enterokinase chops off the OGEN of trypsin, which means of trypsinogen, and now what we have is trypsin. trypsin is now the active form of this protease. And what it can now do is cleave off the OGEN of chymotrypsinogen, which means we then have chymotrypsin. Now what we have are some activated proteases that can break down the proteins here in the duodenum. The whole reason why we have to go through this step here, or this stepwise process, is because if we release trypsin itself and chymotrypsin itself inside the pancreas, it's going to auto-digest the pancreas itself. Now if this happens and we get autodigestion of the pancreas due to the enzymes released by the pancreas, this can result in an inflammatory event that can cause tissue damage and other localized complications. This is the definition of acute pancreatitis. So I'll say that again. Acute pancreatitis is when you have the autodigestion of the pancreas by pancreatic enzymes that result in inflammation and inflammatory cascades that can further result in tissue damage of the pancreas and also tissue damage of other localized areas. That is acute pancreatitis. Now what we need to talk about are the causes of acute pancreatitis, meaning how do we get these enzymes activated and destroying this tissue in the pancreas. Now if we have a look at the incidence of acute pancreatitis, especially within Western countries, so let's have a look at the incidence. What you'll find is that it's around about 5 to 50 people per 100,000 are affected with acute pancreatitis. Now that's quite a large number, 5 to 50 in every 100,000 people. And what you'll probably also find is that the mild cases of acute pancreatitis actually go unreported as well. So this number may actually be even higher. Now if we look at the mortality, so the rate of death, well, the rate of death is usually between 5 to 10% of individuals with acute pancreatitis die from it. But if it's severe, so you can have mild, you can have moderately severe, and you can have severe. If you have a severe case, that mortality rate can even be upwards of about 30%. So this is something that really needs to be looked at and addressed very quickly. What about when we have a look at what's causing, remember I said to you that when we look at what's causing acute pancreatitis, we're going to have the release of these enzymes that's going to break down the pancreas itself. Now what can cause this? Well, two main things. One is acinar cell degeneration. And the other thing, so remember, if the acinar cells are degenerating, they're going to be just releasing their enzymes within the tissue itself, and these enzymes can be activated and break the tissue down. Or it can be due to ductal obstructions. Now, what do I mean by ductal obstructions? Well, what if, for example, the pancreatic duct was blocked? So what if there was something here blocking the pancreatic duct? Or what if something was blocking the ampulla of the pancreas? Or what if something was blocking the sphincter of Oddi at the pancreas? Well, all these things would result in a backlog or increased accumulation of these pancreatic enzymes upstream of the blockage, which means they will accumulate, increase their likelihood of being activated, and then again, autodigestion of the pancreas itself. So these are the two most common causes of acute pancreatitis. But we need to know what actually causes those things to occur. The two most common causes of acute pancreatitis that causes, again, acinar cell degeneration and ductal obstruction includes, for acinar cell degeneration, it's alcohol. And for ductal obstruction, it's gallstones. Now, gallstones are also known as cholelithiasis, okay, or cholelithiases. So these are gallstones. Now, gallstones, let's first have a look at the gallstones and the ductal obstruction. We know that gallstones are going to be produced by the gallbladder. Liver produces bile, stores it in the gallbladder, and if you have an abundance of cholesterol within this gallbladder, it can promote the formation of gallstones, these cholelithiases. So these gallstones can block any aspect of these ducts. So they can block the cystic duct, for example, they can block the bile duct. But think about it, if you were to block the cystic or bile duct, it's not really going to affect the release of the pancreatic juices. So that means that large gallstones have less of an effect on acute pancreatitis than the smaller gallstones. So for example, usually it's gallstones less than 5 millimeters in diameter that are more commonly associated with acute pancreatitis. And the reason being is so that it can go down here and block at least the pancreatic duct or the ampulla or the sphincter. For gallstones, this is the most common cause of acute pancreatitis. So for gallstones, it's between 40 and 70% of acute pancreatitis cases are due to gallstones. When we look at alcohol, it's between 25 to 35% of cases are due to alcohol. But in actual fact, if you were to break it up into males and females, the most common cause for men, alcohol. Most common cause for females or women, gallstones. Okay? So again, two most common causes of acute pancreatitis, gallstones, between 40 and 70% of all acute pancreatitis cases, but the most common cause for women, and alcohol, between 25 and 35% of all cases, but also the most common cause for men. So we spoke about gallstones being less than 5 millimeters in diameter, blocking. Now, not everyone with gallstones will develop acute pancreatitis. In actual fact, less than 7% of people with gallstones will develop acute pancreatitis. And this has to do with a number of different unknown causes. But I think one of the reasons being the size of the gallstone. Let's look at alcohol now. How does alcohol result in acinar cell degeneration? Well, we know that the liver, being the major site of alcohol or ethanol metabolism, the pancreas also metabolizes ethanol as well. And what alcohol can actually do is a couple of things. If I were to just write it down here, alcohol can, one, increase pancreatic juice secretion, pancreatic juice secretion, but what it can also do is increase the viscosity of the pancreatic juice. Now this viscosity, increased amount and increased viscosity can lead to stone formation, so pancreatic stone formation, but also protein plugs. And these protein plugs and stone formation can block these pancreatic ducts or the smaller ductals, okay? What else can alcohol actually do? Well, alcohol can actually increase the amount of fatty acids in the acinar cells. And if you increase the amount of fatty acids in the acinar cells, it increases what's called fatty acid degeneration and can result in 1, necrosis, and 2, oxidative stress. So you can say oxidative stress, which can result in necrosis, and necrosis can therefore result in scarring and fibrosis. Now, if you have scarring and fibrosis, this scarring can block up these ductals and ducts as well. Okay, so these are some of the major causes or effects of alcohol. Now, it's also been shown that alcohol, in this process of increasing fatty acids, resulting in fatty acid degeneration, also promotes inflammation and cytokines from being released, and therefore results in an inflammatory cascade. There's also another hypothesis that because people abuse alcohol, now what you'll find is that binging on alcohol isn't a very common cause of acute pancreatitis, but long-term use of alcohol is associated with it. Now, how? Well, there's a theory out there stating that over time, alcohol abuse can result in subclinical damage of the pancreas, leading to scarring over time, and then these scars can form these ductal blockages, and then that will present as acute pancreatitis. So again, these are the two most common causes. They're not the only cause, of acute pancreatitis. What's the third most common cause of acute pancreatitis? Well, it's something called hypertriglyceridemia. Hypertriglyceridemia. So let's just say gallstones are number 1, alcohol is number 2, number 3 is triglyceridemia. And the hypertriglyceridemia is an increase or an abundance of triglycerides, and what they usually state within the literature is greater than 1,000 milligrams per deciliter. However, some studies are now suggesting that this needs to be higher, even upwards of 2,000 milligrams per deciliter. So I assume that this will continually be updated as well. Now, how does hypertriglyceridemia result in this process? Well, the thought is similar to alcohol in that sense, that it promotes the abundance of fatty acid degeneration, or something called lipotoxicity, which can result in oxidative stress, inflammation, necrosis, and then fibrosis. So this is hypertriglyceridemia, the third most common cause. What about the fourth most common cause? Well, what you can have is something called endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography. What is this ERCP? Well, basically, it's putting a scope down, an endoscope down, with a radioactive dye or a labeled dye, and what you can do is view these ducts of this system. Why would you want to view these ducts? Well, you can have a look for gallstones, you can have a look for strictures or scarring, you could have a look for cancers or tumours. Now, how can the endoscopic retrograde cholangiopancreatography result in acute pancreatitis? Well, the thought is that it can be due to direct damage from the equipment itself. So meaning maybe the endoscope has directly damaged the acinar cells, or maybe the radiographic dye has also damaged the acinar cells, again resulting in a release of the pancreatic juices and the auto-degradation from those pancreatic juices of the pancreatic tissue itself. So these are the four most common: gallstones, alcohol, hypertriglyceridemia, and endoscopic retrograde cholangiopancreatography. They're not the only causes, but they're the most common causes. If you want to know less common causes, things such as drugs, things such as infections, direct damage, so trauma, genetic diseases or genetic aberrations, and even scorpion toxin or scorpion venom. How does scorpion venom result in acute pancreatitis? Well, scorpion venom seems to tell the acinar cells to increase the amount of pancreatic juices it releases, and then it tells the sphincter of Oddi to close up, which means it accumulates here, all these pancreatic enzymes, and auto-digests the tissue. Okay, so these are the different causes. What we now need to have a look at is the clinical presentation and the clinical criteria. Now, what are these clinical presentation, clinical criteria? What am I referring to? Well, usually the patient needs 2 out of 3 of these criteria in order to be diagnosed with acute pancreatitis. So what are these criteria? Well, 1 is abdominal pain. Now, this abdominal pain can be epigastric or right upper quadrant, or it can even radiate to the back. Number 2, biochemical evidence. Now, what do I mean by biochemical evidence? We need some sort of biochemical readout that's going to be indicative of acute pancreatitis. This includes elevated serum, or elevated, what I should say is elevated pancreatic enzymes, such as amylase and lipase, greater than 3 times their normal amount. That's the biochemical evidence. Elevated pancreatic enzymes, amylase and lipase greater than 3 times, where? In the serum. Elevated serum pancreatic enzymes. Okay, what's the third? Well, this is radiological evidence. We need some view to have a look. Radiological evidence, we need a view to have a look and see whether, so sonographically, for example, have a look and see what's going on. So we need to tick 2 of these 3 boxes in order for it to be counted as acute pancreatitis. Now you can also break acute pancreatitis up into various classifications. So what are the classifications of acute pancreatitis? So classifications include mild, moderately severe, and severe. How do they differ? Okay, so for mild, what you're going to find is it usually resolves within 1 week. And there's also no organ failure, and no local complications. I'll talk about what that means in a sec. When it comes to moderately severe, well, moderately severe is associated with transient organ failure. Transient organ failure being less than 48 hours, but still really no local complications. Or maybe some local complications. Let's say some local complications. And then for severe, we have ongoing organ failure. So this is greater than 48 hours. And we have local complications. So the classification can be mild, moderately severe, and severe. Mild usually resolves within a week, no local complications, no organ failure. Moderately severe, transient organ failure, less than 48 hours, and some local complications. And then for severe, it's ongoing organ failure, greater than 48 hours, and various local complications. So what we need to talk about, or what am I referring to when I say local complications? All right, so local complications include the following. It can include an accumulation of pancreatic or peripancreatic fluid. So let's write this down. Local complications include pancreatic or peri. You know what we could do? Let's write it under here, because since these are complications of what's happening here, let's write them down. We can have acinar cell degeneration, ductal obstruction, and what's going to have is when the acinar cells degenerate, it's going to result in trypsinogen, right? And trypsinogen is going to turn into trypsin. Ductal obstruction and trypsin with this ductal obstruction is going to result in a breakdown as well of tissue breakdown. And this tissue breakdown is going to also be associated with these local complications, such as local complications going to include pancreatic, or peripancreatic, so peri means near or around, fluid accumulation, necrosis, so death of that tissue, something called pseudocysts, and hemorrhage. All right. Pancreatic, peripancreatic, fluid accumulation, necrosis, pseudocyst, and hemorrhage. These pancreatic, peripancreatic fluid accumulations are happening near or around or within the pancreatic tissue itself and can be observed by radiological imaging. Necrosis is going to be tissue death. This is going to be death due to secondary inflammatory events and also direct tissue destruction. Pseudocysts, when you've got with the pancreas, you've got these cysts that are forming on the walls of the pancreas, and you'll find that the walls of the cysts themselves aren't made up of epithelia like most cysts. They're actually made up of fibrous or granular tissue, hence it being called pseudocysts. And then hemorrhage, again, bleeding due to the destruction of the tissue as well. So these are the most common local complications. Now, what do you need to do when it comes to treatment though? Well, when you look at treatment for acute pancreatitis, you need to treat the underlying cause of this particular acinous cell degeneration or ductal obstruction. You also need to make sure that fluids are being placed within the patient so that they don't go into shock or have hypovolemia or blood pressure issues. Recoup electrolytes, for example. They may potentially have sepsis or bacterial infections due to some of the damage, so maybe antibiotics. What else do you need? Basically, pain relief as well, because there's going to be a lot of pain associated with the acute pancreatitis. So this could include analgesics, maybe morphine, but remember that morphine can constrict smooth muscle, and so may potentially constrict the sphincter of Oddi, potentially could make things worse, so maybe other forms of analgesic. And that's basically some of the treatment options. Not all the treatment options, but some associated with acute pancreatitis. So hopefully that helps and made sense.